pictures with them?
Yeah, if anyone, but these people are, I think they're having lunch.
Yeah, they're still in lunch.
Yeah.
They came late.
Yeah. So once the LM is over,
Okay.
then we can then we can take on their certificates.
Before they do the talk.
No, after.
Okay, so here.
Yes.
Thanks.
So you can ask Dr. Doesn't have 10 minutes.
Okay.
Yeah, she doesn't know.
Yes.
Okay, she'll have something come back. Then she'll start.
So you heard.
No.
Do you want us to wait for some more people, or would you like to start right away? No.
I don't have any.
So I would like to invite Dr. Diolina.
Good evening.
Sure.
Yeah. Good evening, colleagues. My name is Diolina Qejvani, and I'm a resident in anesthesiology and intensive care at General Hospital Saint Sofia, Sofia, Bulgaria. Today, I will present a rare but potentially life-threatening intraoperative complication during endovascular abdominal aortic aneurysm repair. This presentation was prepared in collaboration with Dr. Georgi Semyonov. Endovascular aneurysm repair is a minimally invasive technique used to treat abdominal aortic aneurysm. As you can see here in panel A, the stent graft is introduced via the femoral artery and advanced into the aorta. And here in panel B, the stent graft is deployed, excluding the aneurysm from circulation and preventing rupture. The aim of this presentation is to present a rare intraoperative complication, sudden complete atrioventricular block, during endovascular aneurysm repair requiring emergency temporary pacing. We present a 77-year-old male patient with significant cardiovascular comorbidities, including ischemic heart disease, previous myocardial infarction, and a reduced ejection fraction. Preoperative evaluation showed sinus rhythm with a heart rate of 72 beats per minute and an ejection fraction of 43%. The patient was assessed as moderate to high cardiovascular risk. The procedure was performed under general balanced anesthesia with endotracheal intubation. Invasive arterial monitoring and continuous and central venosus access were established. Continuous intraoperative monitoring was applied. During the procedure, a sudden onset of bradycardia was observed, which rapidly progressed to atrioventricular block. To better understand the complication observed in our patient, let me briefly review the cardiac conduction system. Electrical impulses originate in the sinoatrial node and are transmitted through the ventricles via his Purkinje system. In complete atrioventricular block, this conduction is interrupted and the ventricles rely on a slower escape rhythm. This results in severe bradycardia accompanied by hemodynamic instability. This explains the sudden drop in heart rate observed intraoperatively. Approximately after 35 minutes after the surgery start, the patient developed severe bradycardia at around 20 beats per minute. The EKG confirmed complete atrioventricular block accompanied by hemodynamic instability. In this case, possible causes of intraoperative bradycardia should be considered, These include myocardial ischemia, increased vagal tone, underlying conduction system disease, as well as drug effects and surgical manipulation. Pharmacologic therapy was administered, but no clinical response was observed. Therefore, emergency temporary transvenosus pacing was performed via internal jugular vein. The pacing was initiated at approximately 70 beats per minute, and the output was adjusted to achieve consistent ventricle capture. Here on the chest X-ray, we can see the pacing lead, which is positioned in the right ventricle, ensuring effective ventricle pacing. And on this side, we have the CT image, which shows where it shows the abdominal aortic aneurysm and the intervention, the endovascular repair. This highlights both the pathology and the intervention performed. Okay. Management of severe intraoperative bradycardia requires vigilant, rapid and systematic evaluation. When pharmacologic therapy fails, temporary pacing becomes essential. Following pacing, the heart rate was restored and the hemodynamic stability was achieved. The patient was transferred to intensive care unit and later received a permanent pacemaker. Severe bradyarrhythmias during endovascular aneurysm repair are uncommon but clinically significant. High-risk patients may have underlying conduction abnormalities. Early recognition and rapid intervention can be critical. Similar cases have been reported in literature, particularly in anesthesia and vascular practice. Bradyarrhythmias during endovascular aneurysm repair are uncommon, but they can occur, especially in high-risk cardiovascular patient. When pharmacologic therapy fails, temporary pacing is the recommended approach. This case highlights several important clinical points. First, high-risk cardiovascular patients require vigilant monitoring. Second, severe conduction disturbances may occur unexpectedly. And finally, temporary pacing must be immediately available, as rapid intervention can be life-saving. In conclusion, sudden complete atrioventricular block during endovascular aneurysm repair is rare but potentially life-threatening, and early recognition and immediate temporary pacing can be life-saving. Thank you for your attention. I would like to thank Dr. Georgi Simeonov and for their support and collaboration. And I would love to answer any question if you have. Thank you a lot. Yeah.
Thank you for your presentation and congratulations on your management.
Thank you.
2 questions, please. You
Yeah.
said pharmacological management. So
Yeah.
what did you use? And the second question is, did you consider transcutaneous pacing instead of transvenous?
Okay. First of all, a pharmacologic treatment, we administered at around 3 milligrams of atropine intravenosus, but no response in heart rate. And that's why we took next step. My mentor put the pacemaker. We performed not transcutaneous, but from jugular vein because it was much easier and a rapid intervention from the jugular vein access. Yeah, I don't know if I answered. Yeah.
Was your first dramatic bradycardia?
Yeah, and that's why I remember even the time, the second, everything.
Okay. You remember your first?
Yeah.
So, looking back now, could you predict that this will happen based on preoperative evaluation?
In my opinion, maybe. There was no diagnosis, any EKG disturbance, but in my opinion, maybe in such risk patients, with as our patient was with heart disease, etc., etc., maybe should be considered to, and we should predict before we start the surgery to have everything accessible, like pacing can.
So there, you needed some time to gather your equipment.
Yeah, yeah,
Okay, those must have been very difficult minutes.
yeah. Awful.
Very
You remember, yeah.
extremely. Okay, any other questions?
Just a different question. What would be the endovascular energy for
What other medication we used? I'm sorry.
What are the medication we could use for pharmacology?
Uh,
That's,
atropine is the first line medication. That's why we use in such heart rate we use it. But we didn't had not even heart rate restored. Even hemodynamic stability was down. So that's why we took this step. Other medication, vasopressors, but this is the second, third line in to achieve, yeah.
You drive the FLD or you stop and because of the block.
We saw on the monitor, and we then I called my mentor. He came, and we saw that we made the EKG, and we saw that it was complete atrioventricular block. Yeah.
You know, this thing is saying that maybe I use something atropine,
Yeah.
FLD.
I think atropine and no response. Yeah.
you the immunizing treatment is not enough. That would take time. Many time we see people, with the daily condition blood. And these are contributions to our tertiary centers. And then it's very difficult to transfer it away. Sometimes the people that don't take it. That really is average to start.
But then we get them to break that because no medication very effective.
Yeah, that's true. And technically, we don't have too much time to experiment. I'm sorry that I'm saying that. With other medication, that's why we took the other steps. Yeah, my mentor actually did it, and I was like, the under internal with the internal jugular vein, the where we, the EVAR, they proceed to femoral artery and goes to abdominal aorta and proceed. Yeah. It's a little bit difficult if they work, for example, for carotid artery, etc., etc. But we had the access. I mean, the jugular vein catheter was in it, so we just proceed in minutes, in seconds. Yeah. Yeah. Thank you.
Because in the European resuscitation guidelines, adult ones, drug condition with adrenaline, unless you are sure that it's caused by parasympathetic disturbance. So before all the agents you mentioned, I would probably myself go with adrenaline. But as I said, I have ER background, so this is my ER people inside me reaching for adrenaline.
Yeah.
Okay, thank you.
Okay, thank you.
So since our next speaker is resuscitating herself back on the 8th floor, she's still able to lunch. I will invite now Dr. Susanna. And if anyone can help us with technical stuff here, we would be